Hello, everyone. I hope your Wednesday is progressing nicely. This is Anna Hoover. It is my privilege to be the Deputy Director of the National Coordinating Center for Public Health Services and Systems Research and Public Health Practice-Based Research Networks. I will be your tour guide today for our wonderful presentation that we're very excited about. This is another in our PHSSR Research in Progress webinar series. The Robert Wood Johnson Foundation has funded approximately 120 research projects over the last 5 or so years for public health services and systems research and through the Public Health Practice-Based Research Networks. And we are using this Research in Progress webinar series for two purposes. One is to provide interested folks with an opportunity to hear some of the emerging research findings that our funded investigators are discovering, and the other is to provide feedback to them on their current research projects and perhaps some ideas about future directions for the projects once the funding period has ended. It is my privilege today to host this webinar series event with Michael Preston. Dr. Preston is a junior investigator. We have had mentored research scientists and junior investigators who have received pre-doctoral research funding, postdoctoral research funding through the Mentored Research Scientist Award. But Dr. Preston is a junior investigator with our coordinating center, and his project has just been wrapping up recently. He's been looking specifically at health disparities, the effects of health insurance coverage expansion and colorectal screening and screening disparities. Dr. Preston is the director of the University of Arkansas for Medical Sciences Winthrop P. Rockefeller Cancer Institute Cancer Control. His current research activities include studying cancer disparities in underserved and uninsured communities, where he applies economic, political, and statistical theory and methods to determine how social factors generate disparities, and for evaluating state and federal policy initiatives in reducing these disparities. He's gained valuable experience in designing an economic analysis of the state demonstration program, which reduces screening barriers among uninsured and underinsured residents in Arkansas. Michael has served as an invited reviewer for the Journal of Healthcare for the Poor and Underserved, and he's received an achievement award for his current research at the University of Arkansas for Medical Sciences. So after that brief introduction, I don't want to take up too much of Michael's time. I know he's got a lot of slides to get through. We'll also be hearing from his mentors, Dr. Glenn Mays and Dr. Rhonda Henry Tillman, near the end of the presentation. So I will now turn things over to Michael.
Good morning, and thank you all for attending this PHSSR Research in Progress webinar. And my name is Michael Preston. I am with the University of Arkansas Medical Sciences. I will be talking to you all about healthcare reform, colorectal cancer screening expansion, and health disparities. For those who would like to contact me after this presentation, you can reach me at mapreston@uams.edu, or for those who like social media, you can reach me on Twitter at M.P.H. I have no financial conflicts of interest to disclose, and I would like to just start right out by giving you all the outline of my presentation. I'd like to give you all the background and significance of this work, the framework used, objective methods, results, conclusions, and implications for this research study. First, some background on colorectal cancer. It's the third leading cause of cancer-related deaths in men and women when counted separately. It's the second leading cause of cancer-related death in men and women when counted collectively. This year alone, we estimate that over 142,000 new cases with more than 50,000 deaths as a result of colorectal cancer. You may hear me refer to colorectal cancer as CRC. Good news is that over the past 20 years, the overall death rate has decreased, but the bad news is that disparities remain among medically underserved populations. When we talk about colorectal cancer, we have to talk about the role that colorectal cancer screening plays in early detection, because it has been a major contributor to the overall decline in new cases and deaths from colorectal cancer. Screening allows for detection and removal of these precancerous polyps before they actually progress to cancer. Screening also allows for early detection when disease is easier to cure. And because of this, there has, been major improvements in treatment over the years. And uh, because of this, the Healthy People 2020 set a screening goal of 70%. Next, when we talk about, the incidence mortality for CRC, decline over the years, we see that there are still disparities that continue to exist amongst certain groups. Because of this, we wanted to, it's important to explore these plausible explanations for these disparities. When we talk about compliance and adherence to screening guidelines has been seen as a way of reducing these disparities. Higher mortality rates remain among disadvantaged groups, underserved, that are part of these racial and ethnic minorities, and rural populations that tend to be low income, underinsured, and uninsured. Racial and ethnic minorities, such as African Americans, they're less likely to be screened and more likely to die as a result. One study showed the 5-year survival rate in African Americans was 53% compared to 63% whites from 1992. This graph here shows colorectal cancer screenings as of 2010. This is from Center for Disease Control. And as you can see, states that are close to that 75%, 70% screening are mostly your northeastern states. Some northern states are in the dark blue that shows that they have screening rates that are considered up to date based on Center for Disease Control definition of being up to date. And because some screening rates were not where some states wanted them to be, select number of states were proactive and passed state mandates in hopes of improving colorectal screenings and reducing disparities. And this map shows states that have some type of insurance coverage mandate in place 1997 up to present date. So you may be asking, what is the insurance coverage mandate for colorectal cancer? This is a policy or law that requires insurers to cover the costs of a medical service that they would not otherwise if the mandate was not in place. Not all states pass these mandates related to colorectal cancer, and there are variations in the types of mandates that were passed. Talk about variation, we're referring to the differences, the amount of cost sharing. These mandates as a mechanism to reduce out-of-pocket expenses as a way of increasing. Here's an Arkansas example, Act 2236, Colorectal Cancer Act of 2005, established colorectal cancer control and research administration project. Co-presenter Dr. Rhonda Henry Tillman, she'll be providing some additional standards. Policy also required insurers to cover colorectal cancer, but with we saw in the state mandates, there were two main exemptions. The first exemption were employers' self-funded benefit plans. They were exempt from these mandates, mainly your large employers such as Walmart. There were no restrictions on cost sharing. So in 2010, with the introduction of the Patient Protection and Affordable Care Act, it was introduced as a mechanism to decrease the overall number of uninsured Americans, reduce the overall cost of health care, and provide insurance coverage mandates for preventative services. And by doing this, it closed these loopholes that we saw in state mandates. Or self-funded benefit plans were no longer. Also, now we have no cost sharing for receive preventative health. This next graph shows policy adoption over time, and we can see the red line shows states that actually implemented some type of insurance coverage mandate from 1997. We see 1997 all the way up to 2010. Blue line shows states after they started implementing the insurance mandate for states that not have mandates. And the green line actually shows about 17 states had no mandate in place before healthcare. So based on the law of demand, what we expect to see is as out-of-pocket costs decrease, we should see an increase in overall quantity of colorectal cancer screenings. The goal of this research study is to estimate the effects of health insurance coverage mandates or expansions on overall colorectal cancer screening rates and colorectal cancer disparities. So in order to carry out this study, you use time series analysis with difference and difference approach. What the difference and difference approach does is it allows us to measure the difference in screenings before and after the policy. It also allows us to measure difference in CRC screening between treatment and control groups. The treatment groups for this study were the non-mandate states. Our control groups were the mandate states. And this difference in difference approach allows us to identify causal effects of the Affordable Care Act on the CRC screen. The data used came from the Behavior Risk Factor Surveillance System, which the study population of U.S. adults age 50 or greater. Also, the National Cancer Institute State Cancer Legislative Database, where provisions, exemptions, and enforcements of the data set was to assess state-level estimates of health behaviors, healthcare utilization by building a state year longitudinal data file. This data file provided information on different types of CRC screenings that were used, the latest test was performed, insurance status, race, ethnicity, and socioeconomic status for the years. Our analytical sample, we had over 34,000 sample with 25,000 in mandate states, over 8,000 in non. And for the analysis being conducted, multiple models based off this difference in difference. This model estimated in this analysis is described by Y, which is our outcome of interest. Beta 1 reform is the indicator equal to 1 when healthcare reform policies become law and 0 otherwise. Beta 2 post is an indicator equal to 1 if the state has no mandate prior to healthcare reform policies, 0 otherwise. Beta is our state fixed effect, and the coefficient is our beta 3, which is described as our difference in difference estimator. This is allows to measure the effects of healthcare reform on colorectal.
I'm sorry to interrupt, Michael. We're having some background noise. If you have your speaker or your phone not muted, please go ahead and mute it. If you don't have a mute button, please press *6. If you need to ask questions at the end, you can press #6 to unmute. But for right now, please ensure that your phone is muted so that we can adequately hear Dr. Preston's interesting model specifications here. Thank you. Michael?
All right, and so our next specification model, we wanted to use not only the difference in difference approach, we wanted to use what we call a triple difference estimator. Basically, we're adding a third variable to this model, and this allows us to look at some of the disparity things, variables that we think, race, ethnicity. We also want to look at insurance status as a way of determining whether or not people who are uninsured were were affected by some of these mandates. Based on that, we have the same similar model where we have Y as our outcome of interest. We have our
Miss Jack on the end of it.
condition of race. Race variable is described as 1 if the individual is a racial ethnic minority and 0 otherwise. And for the second model where we have the insurance status, we're uninsured, that is an indicator equal to 1 if the individual is uninsured and 0 otherwise. Still have our theta, which is our state fixed effect, and our coefficient of interest is beta 7, which is our triple difference estimator, where you see the reform, post time race. For the first one, on the second estimation model, form time post time uninsured. This is our measure of the effect of healthcare reform. So what we find is, the first graph here shows colorectal cancer over time. See from 1997, red line is a fecal occult blood test. It shows screening over time for that particular quality. See the blue line shows endoscopic screening tests over time. See from 1997 to about 2000, pretty much screening was kind of flatline, but then something happened in 2000 that caused about a 15% increase in CRC screening. And we accredit this to the Katie Couric effect. And for you all that know, Katie Couric was a celebrity who wanted to increase awareness about colorectal cancer screening. So see this increase from 2000 to 2001. And then after 2001, the fecal occult blood test, the red line, kind of just flatlines, actually goes down 2000. The blue line, endoscopic exam, continued to increase 2001, 2012. This next graph shows colorectal screenings, those that were considered up to date over time. So we see overall compliance from 97, we have about 40%, all the way to 2012, we see about 70%, 60, 69% of people that are compliant when we talk about those who are up to date with their CRC recommended. This first table is a descriptive statistic of the study population that received any colorectal screen, individual characteristics only. As you can see, those individuals, the mean age for individuals that were older were more likely to receive colorectal cancer screening versus those that were younger, about 64 years of age. We look at mandate states versus non-mandate states. We have about the same amount of individuals, about 61 that said they've had received colorectal cancer screening over time. Look at healthcare reform before and after healthcare reform. We have about 64% of that they have received colorectal screening after healthcare reform versus 58% for healthcare reform. And these are the summary statistics before and after healthcare reform. Those individuals that did not see the doctor due to medical costs increased about 9% for healthcare reform, almost 13% after healthcare. Look at individuals that had a personal doctor, decreased from about 94%, 89% after healthcare. After healthcare reform, the percentage of individuals who self-identified themselves as white, 82% to about 77%.
Hello.
I'm sorry, I'm going to interrupt once again, Michael. I'm very sorry to keep doing this to you, but someone's phone is not muted at present, and it's making it very difficult for others to hear Dr. Preston's presentation. So if you could please double check your phone, *6 to mute if you don't have a mute button. Thank you, and I'm going to turn it back over to you, Dr. Preston.
Well, thank you. And so here are some of the main findings from this particular research. We find that we look at the healthcare reform effect. We want to, provide the marginal effects of healthcare reform on CRC screening. And so when we look at our difference in difference estimator, we find a coefficient of 0.16. And when we calculate the marginal effects of this, we get a value of 0.034. And what this means is that the estimated marginal effects of healthcare reform increase the probability of having a colorectal cancer screening by 3.4 percentage points on average among adults aged 50 to 74 in states that did not have mandates in place. So this is, the main finding from our first specification. And then when we look at our next specification models, when we started looking at, these triple difference estimators, then what we wanted to do, we ran 4 separate models. So we find healthcare reform effects for non-whites versus whites, get a coefficient of -0.10, and when we calculate the marginal effects, we get a value of -0.025. And what this means is for non-whites, we see a reduction, in of about 0.5 percentage points, non-whites versus whites, that actually as a result of healthcare reform. But when we look at African Americans versus white, reduction, marginal effect, -0.05. And when we also look at Hispanics versus whites, we get a marginal effect, -0.0156. The next model, look at the healthcare reform effects of uninsured versus insured. Get the marginal effects of -0.0487. And so based off of these results, we find that healthcare reform increased the probability of having a colorectal cancer screening by 3.4 percentage. Based on these numbers, we estimated that 2.87 million additional age-eligible persons will receive a colorectal cancer screening as a result of healthcare reform. We saw also that it increased screenings among whites. We saw that it decreased among screening among African Americans and Hispanics, but we saw that it increased among those that were insured. So we found, evidence that the Affordable Care Act actually, influenced CRC screenings, and our analysis supports the implementation of healthcare reform and stronger policies that increase colorectal cancer screenings overall. So what are the policy implications? The policy implications for this research, it demonstrates that insurance mandates increase colorectal cancer screenings by reducing out-of-pocket costs. Future reforms, healthcare reforms that increase access to preventative services such as colorectal cancer screening are likely with these low out-of-pocket costs and will increase the number of people who are considered up to date. And we know that starting this year, all U.S. citizens are required to have health coverage, and so we expected the demand to increase for colorectal cancer screening. So the policy implications, when we talk about disparities, we need to be able, because we saw these reductions relative, whites to non-whites and other groups, we need to be able to identify the best ways to design health systems for preventative services that target medically underserved populations, because these disparities continue to increase with health policies that reduce out-of-pocket expenses. Additional measures are required to reduce these disparities and screenings among non-whites and Hispanics. And then it's important to know if healthcare coverage expansions that started this year actually disparities among. And that's that's all I wanted to provide. I know that I have some co-presenters that will also provide some additional information from their standpoint. So if you need more information regarding this study, you can read ms.com or hit me on Twitter at mdunp. Thank you.
Thank you so much, Dr. Preston. That's some very interesting findings in that study, and we know you've been working with two established and esteemed mentors on this project. I want to check in and see if Dr. Mays has made it on the phone yet. He was getting off of a plane and coming straight to the call. Dr. Mays, are you with us?
Yes, Anna, I am with you.
Wonderful. Well, I'm going to quickly read through your bio, and I'll also go ahead and read through Dr. Henry Tillman's bio, and then I'll just pass the baton to you, sir. Dr. Mays studies strategies for organizing and financing public health strategies, preventive services, and prevention policy, with a focus on estimating the health and economic effects of these efforts. He directs the National Coordinating Center for PHSSR, funded obviously by the Robert Wood Johnson Foundation and based here at the University of Kentucky. Dr. Rhonda Henry Tillman is a surgical oncologist specializing in breast oncology at the University of Arkansas for Medical Sciences, a professor for the Department of Surgery at UAMS. She serves as practice director of the Women's Cancer Clinic and is director of cancer control for the Winthrop P. Rockefeller Cancer Institute. She is board certified by the American Board of Surgery. With those brief introductions, I will hand things off to Dr. Mays.
Great, thank you, Anna, and it's a pleasure to be sharing the research in progress virtual stage with Dr. Preston and also with my my very good colleague Dr. Tillman. I'm going to offer a couple of comments, reactions about Michael's work, a few issues kind of probably from a health policy and also a methodological perspective, and then I'm going to turn it over to Dr. Tillman so we can hear her reactions and as well. But just first to kind of put Michael's study in context, this issue about question about the role of price in driving the demand for and the utilization of preventive services has been with us for a long time. At least in the modern era of health policy discussions, this issue was explored empirically in some depth way back in the mid-1970s during the Rand health insurance experiments, where we randomized people to different types of health plans with different types of cost sharing to look at the effects of those plan designs and especially the effect of cost sharing on healthcare utilization and health outcomes. And some of those studies looked specifically at preventive care, and in fact, that study taught us that preventive services, people tended to be more price sensitive to preventive services than they were to other types of healthcare services. So when you raised the price of preventive care by putting people in health plans that had larger out-of-pocket costs, deductible cost sharing, we saw demand for and the utilization of preventive services actually drop more precipitously for preventive care than for other types of care. And so that concern about the price sensitivity of people to preventive care has been with us for a long time, and certainly back to the back to the 70s and the Rand health insurance experiment. Obviously, with the advent of the Affordable Care Act, there's been the inclusion of a provision that requires health insurers to provide first dollar coverage for evidence-based preventive services. The public health and healthcare community has obviously seen that as a big success, and we've all been quite hopeful that provision of the Affordable Care Act in particular is hopeful that that's actually going to lead to greater use of preventive services and ultimately improvements in population health. And certainly colorectal cancer screening is is one of our one of the the best tools in our our clinical preventive services toolbox because of its potential not just to detect cancer early, but as Michael said, to literally prevent cancer, to detect precancerous lesions and stop them from actually progressing to cancer. So estimates are that we can, if fully deployed, that if this preventive care technology could reduce maybe up to 80% of the colorectal cancers that we see. So a lot of enthusiasm. In a variety of studies, Michael's included, have been conducted over the last couple of years, looking at the early effects of this component of ACA. When we take preventive care, the cost of preventive care down to zero, at least for people who have health insurance coverage, what happens to utilization? And unfortunately, the studies that we've seen so far come out over the last year have not painted a very rosy picture. They have not suggested that this component of ACA has done much to move the needle on many types of services. Michael's study is a little different. He's looking not just at the ACA, but he's looking also in his estimates of the effect of insurance mandates, including the effects of these earlier state mandates that Michael talked about, that states began implementing, some back in the late 1990s. Many, like Arkansas, implemented their laws more recently during the first decade of the 2000s. And essentially what Michael's estimates, Michael's kind of first, leading specifications do is give us an estimate of kind of the average effect of these state mandates, plus in the last year of his data set the effect of the ACA, the more comprehensive ACA mandates there. And as Michael said, he actually does have some good news here. He does show that overall rates of screening appear to increase when you have a coverage mandate in place. How much of that is due to the earlier state mandates versus the more comprehensive ACA mandates? I would say that Michael's specifications aren't really positioned yet to be able to differentiate that very clearly. I think his estimate showing an overall positive effect of coverage mandates on colorectal cancer screening is really kind of a weighted average estimate of the earlier state mandates, plus in the last year of his data set, that ACA mandate. That effect is overall, it's fairly small, and so maybe that's disappointing to some people who might have hoped to see a larger effect from lowering the price, improving coverage for these services. And he's also got some disappointing news as well, and these mandates don't appear to have done much to close the disparities in screening, particularly the racial disparities in screening. And so we might ask, well, why? Why don't we see a larger effect, and why in particular don't we see effect on the disparities in screening, which are a critically important issue? I think one of the implications here is that price is not the only problem when it comes to why we see racial and ethnic and socioeconomic disparities in colorectal cancer screening. And so there may be non-price factors that are more important drivers of why minority populations and low-income, low ESCS populations are less likely to get screened, or more having to do with the time cost of getting these screenings, and the fact that the people have to take time off from work, or they may have to travel long distances in the case of rural settings like in Arkansas, where where Michael and Dr. Tillman work. And so some of those non-price issues that may be more of an issue, again, of competing priorities and time costs, the inability to get time off from work to get screened, the fact that people in low-wage jobs don't have paid leave and other kind of provisions that allow them to take time off. So if they, getting screening may mean a missed paycheck, which can be challenging for the population. Non-price factors are probably part of the story here. I also think, again, that we're in terms of the provisions here, which are just only the last year of Michael's time series. I still think we have yet to see the full effects of the first dollar coverage provision of ACA play out in 2011, and probably even now 2014, we're still not yet seeing the full effects of going to zero price, going to full first dollar coverage under ACA, because there is this grandfather provision of ACA that says for health plans that are already in effect, they only have to move to first dollar coverage of preventive services when there's a change in that plan design. And so there are still, the data is still a bit fuzzy on this, on how many of these grandfathered plans, these kind of pre-ACA health plans, are still into effect now that we're 4 years out after ACA. But there's a non-trivial number, no doubt. And so I think this grandfather provision is still also dampening the effects, certainly dampening the effects in 2011, which is the last year of Michael's panel. And there's also some interesting issues about how Medicaid, how state Medicaid plans have responded to this mandate, because strictly speaking, state Medicaid programs don't have to comply strictly. They don't have to comply strictly with this ACA mandate for first dollar coverage. So Medicaid plans, technically, they can still charge copays for screenings. They actually have an incentive to reduce those copays to zero, because they can get a bump up in their FMAP, their federal matching rate for Medicaid, but they're not required to, and some states have not done that. Certainly the states that are not expanding Medicaid have not done that. Medicaid plans also tend to have other kinds of limits on healthcare utilization. The state of Arkansas, for example, we bumped up against this in looking at the early Arkansas colorectal mandate. The state Medicaid plan has a limit on the number of outpatient visits that adults can receive during the calendar year, a pretty hard stop at 5 visits. So if you've already, if you're a person enrolled on Medicaid, you've already used up your 5 visits. You're not going to be able to get a 6th visit to go in and get your colorectal cancer screening. So those other kinds of utilization limits that Medicaid plans tend to use to contain costs can also complicate these issues, and ACA hasn't necessarily relaxed those kinds of constraints. So those are a few thoughts. I think Michael did a great job using some good methods here, using a nice design, taking advantage of existing data sitting out there on the website that any guy can pull down and use to evaluate the effects of health policies on public health, and using some cutting-edge research design, quasi-experimental research design, the difference in difference and the triple difference approach here. So I think some good methods in play here. Michael's showing, demonstrating really what the power of informed methodology combined with using smart use of existing data sources to study important issues around the public health impact of ACA and health policy reform. So with that, let me turn it over to my good friend and colleague, Dr. Rhonda Henry Tillman. I will say that she's, in addition to the introduction that Anna gave, the many accomplishments that Rhonda has achieved over her period of time. She's really a national scholar when it comes to cancer prevention research and cancer disparities research. She has been for more than a decade a NCI-funded PI, implementing some very important community-based research around cancer disparities and health policy research around cancer disparities in Arkansas and the Mid-South region. And she is no slouch when it comes to health policy design and implementation in general as well. I learned a lot from her about the real world of health policy from working with her during my 8 years in Arkansas. She was a very important player in the effort to design and then implement again, Arkansas's 2006 colorectal cancer mandate, and some very interesting work that she was able to do on the tails of that legislative accomplishment. So with that, let me turn it over to Dr. Tillman.
Thank you, guys. I like to thank Michael and commend Michael on his work, really taking what he has seen from a policy perspective and putting it into work. And coming from a clinical background, having the collegial support from Dr. Mays, and also working with Dr. Preston has really made a difference in work in prevention for our patients that we see on a daily basis. And I think having that team together does really impact what we're trying to do. My first comment is that Michael having the insight to look at the Affordable Care Act and its impact on colorectal cancer screening outcomes. It's very interesting when myself and Dr. Mays and Dr. Preston worked on this in 2005, we knew the biggest bang for our buck would to be look at the policy impact on how we can get change to impact disease state. And colorectal cancer was one of those that we had the most evidence-based science to support. So as a part of that, we worked together to look at how to provide evidence-based science to our legislators and then look at the impact on what it would do from a policy perspective in changing screening outcomes in colorectal. We didn't know we had so much work to do, but providing them with that evidence-based science, we were able to get legislation passed initially in 2005 where they gave us support to do a capacity assessment of the state. And that's a major thing that I think a major product of what we were trying to put across to our legislation. There are multiple factors that impact or being multifactorial on whether an individual gets preventative services. And Dr. Mays alluded to some of those competing issues, capacity, access, provider recommendations. But when Michael began to look at the policy impact on whether these people would get screened and also following that with the Affordable Care Act is very important. And so we have to continue to look at what's occurring from a policy perspective because we all like to think we're all going to do the right thing. I wish they gave me an option not to pay taxes, but I don't have one, so I pay them. And so it's the same thing with health care, and that's why they had to come up with the Affordable Care Act because we were losing so many individuals because of the lack of resources and access to health care because of no state mandated or national mandates to support health care. And so this just goes to show that overall rates screening rates increase with coverage and mandates. And we showed that earlier, but as we continue to do that, one thing that I've noted is that we have to continue to look at research and policy impact because one of the things, the reason I think so many individuals know about the Affordable Care Act is because they saw it on TV or they were exposed to it. But a lot of times we have these policy changes or policy recommendations that aren't put out there and individuals don't know about it. And still today, you would be surprised of the individuals that aren't aware that within the Affordable Care Act, that prevention services are covered without copays. And so it'll be very interesting on my policy researchers and leaders continue to look at this impact. So I'd like to commend Michael. We have a lot of work we need to continue to put forth in addressing health care, especially at the policy level.
Thank you, Dr. Henry Tillman. And thank you, Dr. Mays, for your comments as well. I think it's time now to open the floor to some questions. I've seen in the chat box some people are in the process of typing questions, and you can type those questions into the chat box on the bottom right of your screen, or you can chime in by unmuting your phone. I'll start with Nate's question since he has already typed one in. He says, hi, Dr. Preston. How did you deal with the different methods of weighting in BRFSS? Sorry, one moment, that jumped. How did you deal with the different methods of weighting in BRFSS data between before and after 2010 to get the trend about colorectal screening over time? Thank you.
Okay, thank you, Nate, for that question. As far as weighting information, the data, the births data before and after, the I guess one of the questions placed because of the new design or the way that the Burfess started measuring stuff after 2011. So these effects actually were considered at the actual modeling. So weights we or some of the difference in different models in order to get before and after the Burfess started doing measurements.
Thank you, Dr. Preston. We have another question, this one from C.K. Smith. Please discuss the discouraging effects of financial liability for the difference between the cost of a routine colonoscopy and a diagnostic colonoscopy upon low and moderate income ACA enrollees. Are there efforts in place to prevent these ACA enrollees from receiving large bills in this difference? We see this as a huge barrier to improving colonoscopy screening. Thank you very much. I think that question could be open to all three of our panelists, if anyone would like to jump in.
Can you repeat it? I'm sorry.
Please discuss the discouraging effects of financial liability for the difference between the cost of a routine colonoscopy and a diagnostic colonoscopy upon low and moderate income ACA enrollees. Are there efforts in place to prevent these ACA enrollees from receiving large bills for this difference? We see this as a huge barrier for improving colonoscopy screening. Thanks very much.
Yes, just to clarify, you're asking about screening and diagnostics. So screening is completely covered, but if you have an abnormality, then that becomes a diagnostic procedure, and then your copay does go into effect. That's one of the things that we have to provide more education to the individuals regarding those things. But if you have something there, you would want it removed. The unique thing about the colonoscopy that it could typically, diagnostic is when they come in, say that they're having blood in their stool or they have a change in bowel habits. That's no longer a screening test, so they would have to go along with the rules of their policy, their insurance policy, on paying that diagnostic evaluation. So if they don't have any diagnostic symptoms, then it does not become a diagnostic test. So you have to be careful on why you're ordering that test, and that's a lot of information in regards to the provider who's ordering the test, whether they're ordering a screening or diagnostic. Hopefully that helped.
Thank you, Dr. Henry Tillman. We have had a question about the definition of preventive services, and I just wanted to note for those not following along in the chat box, I have pasted a link to Health and Human Services fact sheet that defines the preventive services covered under the Affordable Care Act. So that link is in the chat box. I think you can probably also Google it if you happen to be on your phone and not following along on screen. It looks like C.K. Smith is typing perhaps a response to Dr. Henry Tillman. Are there other questions? Would anyone like to chime in from the phone?
I might just chime in on that preventive services question. Again, from the ACA's perspective, in terms of which preventive services qualify for the first dollar coverage under ACA, it's got to be a preventive service that has been reviewed by the U.S. Preventive Services Task Force and that has been graded by that task force as having a grade A or a grade B level of evidence about the effectiveness of that service in terms of improving health status. And so so that's really, it's how the U.S. Preventive Services Task Force has reviewed the evidence about the services, and if they've graded that service as having a high level of evidence behind it, grade A or grade B, then under the ACA law, health insurers have to cover that service with zero zero copayment or deductible, first dollar coverage.
Thank you, Dr. Mays. And rerouting back to the discussion of diagnostic and routine colonoscopies, I think perhaps Dr. Henry Tillman might be best situated to respond to this, but obviously we welcome response from all of our panelists. C.K. Smith has replied, my understanding is that a test is recoded as diagnostic when polyps are found during the routine colonoscopy. My question was in reference to these recoded tests. Dr. Henry Tillman, do you have any insight in that area?
Yes, they are, because a screening procedure can easily turn into a diagnostic procedure if an abnormality is identified. So if something's identified, for them to do that procedure is now diagnostic. So doing a polypectomy would be diagnostic at that point, and they recode it as a diagnostic procedure as a part of the screening. I would have to look specifically at how specific providers are billing it.
Thank you. Are there any questions from the telephone? A reminder that if you have pushed *6 to mute your line, you can push #6 to ask a question at this time. Or you can type questions in the chat box. All right. Hearing no additional questions, I think it remains to me to thank again Dr. Preston, Dr. Mays, and Dr. Henry Tillman for their time and their very interesting insights during today's call. And to remind folks that we do have other upcoming webinars in our Research in Progress series. As I mentioned earlier, there are approximately 120 funded studies in the PHSSR and PBRN portfolios, and we're trying to get information about all of those out to folks, and they range across cost, value, bridging health and healthcare, a variety of areas of the PHSSR portfolio that came out a couple of years ago on workforce, finance and economics, information and technology, system structure and performance. So we have a wide variety of presentations coming up. I believe Ann is scrolling through some of those right now. We invite you to attend the ones that are of interest to you, and if you have colleagues who might be interested in some of these findings, please invite them to join us as well. If you have feedback on this webinar series, we would love to hear that as well. Please contact us here at the Coordinating Center, and Kelly's contact information is up there. And I hope you found this session as valuable as I know I did. Thanks again to Dr. Preston, Dr. Mays, and Dr. Henry Tillman, and have a terrific day.
Thank you guys all.